All right, everyone. Welcome to another episode of the Gestalt Education Show. My name is Dr. Taylor Premer, along with my co-host, Dr. Brett Winchester. Brett, you're repping someone's T-shirt today.
Bow Beard from the farm.
I love it. So we're trying to shout out as many of our friends as possible with the awesome T-shirts. He's got a great one now. So, well, we're lucky enough to be sitting down with one of the experts in the radiology field, especially when it comes to the chiropractic field, Dr. Dan Haun. So, Dr. Dan Haun is a chiropractor. He's also a chiropractic radiologist, a DACBR. He's the director of the resident program and the fellow program of education at Logan University. He's also renowned as one of the experts in the world when it comes to diagnostic ultrasound, and he's kind of transcending the world as far as what we can and can't do with diagnostics with an ultrasound. And then he recently just got awarded the 2021 Academia of the Year Award presented by the ACA. And so we're so glad that he got that award. There's no one probably in this world that deserves it more than Dan.
He's the most underrated guy in the profession, I would say.
So we've both been lucky enough to work with him at Logan University. And, I've been lucky to read so much of his content on PubMed and all the other sites and stuff like that. And so we're really lucky to be sitting down with him. But so Dan, maybe you just want to comment on kind of what it means to win that award first, and then
Sure.
What it means.
What does it mean? That's a great question. First off, it was a total surprise. That's probably an award that I can honestly say that it wasn't on my life goal list to win the Academician of the Year award, but it's a great honor. A couple of people I really look up to have won the award in the past. And to be honest, when the ACA reached out to get in touch, I thought they were asking about an upcoming lecture they wanted me to give or something like that. But then when they dropped the bomb of that, hey, you've been selected as the Academician of the Year, I was floored. So it's a great honor. And a great recognition. My mentor, Dr. Norman Kettner, I remember when he won it roughly 15 years ago, whatever the case was, and I never thought I would be even in consideration. So I'm humbled. I'm still processing it, and I think it's a reflection of just a good support system, people that I've worked with and interacted with in the past, and we've been able to do some cool stuff. So hopefully that keeps happening.
Absolutely. Can you maybe next, Dan, just kind of take us through, the process of becoming a DACBR, what the process of becoming a resident, and then following through with all that stuff, it kind of looks like.
Sure. Yeah. So the process is, first and foremost, somebody has to decide that they want to commit the time and the effort to that process. There's nothing magical about becoming a DACBR. It's just, can you commit to the residency program? Because in order to sit for the American Chiropractic Board of Radiology exam, you had to have completed a 3-year residency in chiropractic radiology. And there are residency programs at multiple sites within the chiropractic education realm. Logan is just one of those sites, and so that happens to be where I did my residency. So the process is somebody who graduates from chiropractic school decides they want to further their training in the discipline of diagnostic imaging. And so then they apply to various residency programs. The way the residency programs in radiology at least work is they're all kind of very individual. And so there's not a standard application that gets sent out to all of them. You're not matched to a program necessarily. You just have to find a program that fits you as far as your interests go, as far as the timing of everything goes, from when you graduate to when you want to start the residency. And obviously, you're always planning 3 years out when you finish, to the timing of the board exams and all that. So the residency is a big commitment from a time standpoint. It's a full-time position. The way we have it at Logan is you're an employee of Logan, so you receive salary and benefits and all of that. But your time is spent primarily in our radiology department, where you are tasked with interpreting the studies that come in through our outpatient clinic and through field doctor referrals. One unique feature of Logan's residency is the exposure we give our residents to diagnostic musculoskeletal ultrasound. That doesn't happen at every residency. A couple have added that to their repertoire, so to speak, but we were the very first ones to initiate that for our residents. And we have a fellow level position that if when they finish their 3-year residency, if they would like to continue for an additional year here at Logan, they can apply for the fellowship. And if they are awarded the fellowship, they get to stay another year and focus not exclusively, but primarily on advanced imaging, which is heavily diagnostic ultrasound oriented, but they'll also further their skill and training in interpretation of MR, CT, bone scan, PET scan, and all the things that we consider advanced imaging these days. So after the end of those 3 years, you sit for your board exams. There are 2 parts that the American Chiropractic Board of Radiology puts on. The first part is the written exam, and you pass that. That makes you eligible to sit for the second part, which is the oral or the practical examination. And if you're successful there, then you're awarded your diplomate of the American Chiropractic Board of Radiology, and you're officially minted a DACBR at that point.
I love it.
So how, with x-ray utilization being down, kind of the guidelines changing on plain view x-ray, Dan, how has it changed in the last 18 years as far as the program? I know you and I are about the same age, so I know early on, I mean, lots of plain view x-ray, and now I know we're going to talk about some diagnostic ultrasound later, but how is it changing for you guys as far as the program?
Yeah, well, luckily, maybe that's not the right term, but in the world of the chiropractic radiologist, even though one of our favorite things to do is look at images, in particular radiographs, we've always been a strong proponent of using imaging in the most evidence-based manner possible, one that will improve outcomes in the patients with the least amount of adverse effects, both biologically and also psychosocially. So we've been preparing for this for the past 18 years. We kind of saw that the guidelines, especially for spine pain, were moving away from using routine imaging on every patient and also serial follow-up imaging, that the evidence just wasn't in that side of the equation. So has our imaging volume decreased over time from a plain film standpoint? It has, but what we've seen increase are higher yield exams. So I'll tell you, back in the day when I first started, even in my private practice, image interpretation practice, just seeing a lot of negative studies. And now that we're starting to use more evidence-informed guidelines, we see a lot more interesting findings on the radiograph. So that's been a bonus. Even though we see fewer images, there are a lot more positive results as far as seeing things on the films that will actually impact patient care. So that's been one of the aspects that I think is positive. Another one is advanced imaging has also grown, but that's not something that chiropractors do in their offices. So chiropractic radiologists, depending on where you are and where you practice, in the state licensing laws, some imaging centers like to use the services of a chiropractic radiologist, and they will provide the interpretation on the studies that are referred to the imaging center by chiropractors. So they use it primarily as a marketing tool, but we're happy to provide the service on our end when chiropractors need the MRs or CTs of their patients read. So we train our residents and our fellows in advanced imaging interpretation as well, primarily of the musculoskeletal system, which includes, in our context, the spine. So we've seen an increase in advanced imaging and a slight decrease, of course, in plain film use. But I think the goal of everybody, whether you're a chiropractic radiologist or a clinician, is just to get the best outcomes you can for your patients. And if that means sacrificing a little imaging volume, that's fine, as long as we keep getting those good outcomes, because you don't always need to take a picture to get great outcomes. And although that's somewhat controversial depending on who
You're
you
not gonna
follow
do
and what
it
you
on
read.
air.
Well, maybe that's a good next step of like, what are some of the misconceptions right now that you've seen with radiology or even with chiropractic radiologists?
Yeah, yeah. Well, I think that a lot of the use of radiography, taking x-rays in the chiropractic practice, has a lot more due to practice management selection than actual, patient care decisions to some degree, because there was a time in chiropractic, this was before my time in chiropractic, but there was a time when x-rays were a good income stream for chiropractic offices. You could take x-rays and you get reimbursed, and that was part of the business model, the reimbursement model for chiropractors. But with all the scrutiny that's put on imaging these days, it's getting harder and harder to get reimbursed for imaging, unless you can fulfill certain criteria. And this is in regards to third-party payers. So there's less of an incentive for chiropractors to utilize imaging, because most chiropractors don't use it to look for pathology necessarily. Although I will highlight one controversial thing, just because I hear it a lot and I want to hit it, is that most chiropractors use x-rays for so-called biomechanical analysis. But so far, we don't have great data, or any data for that regard, showing that what you see on a film is any better than using these magical tools we have and our eyes to analyze the patient, especially when it comes to really what's most important: how's the patient moving today? Because an x-ray is just a picture. It's a snapshot in time. And so we got to emphasize that we have to treat the patient and not the pictures. But another misconception is that radiography is a good screening tool. Radiography is probably one of the worst screening tools we have as far as pathology goes. So I hear frequently that, oh, we need to take x-rays on every patient because they might have a problem or something serious going on. And so if that attitude or that idea is the rationale for using imaging, then you're assuming that radiography can actually catch all the bad stuff that might be lurking in your patient. But that, unfortunately, is just not the case. Radiography, we know the sensitivity of radiography for bone pathology is not great. For example, you have to have 30 to 50% bone loss or bone destruction before you'll even notice it on a plain film. So that means a pathology has to have progressed quite a ways before you'll even see it. And the soft tissue pathology, oh man, even more so. So the idea that you need to use radiography to screen for hidden pathologies is flawed. Now, the specificity of radiography is pretty good. So when there is a positive finding, then it's likely a true positive. But one of my mantras is never trust a negative radiograph, because there can be pathology in that patient. The film just won't show it. So if you get in the habit of taking x-rays and saying, oh, I don't see any pathology, you must not have any hidden pathology, then you're just fooling yourself. Your physical exam is actually much more sensitive to pathology, and that's why we teach our students to screen for all those, proverbial red flags that may be lurking in the patient that suggest serious spinal pathology. And the other stuff that's not so serious is really where a lot of the controversy lies. Is, well, can we use x-rays to diagnose static malpositions of vertebra, and is that even something that's important? I would say, and I can just really speak for myself, but also for the people I've trained with and trained, that most chiropractic radiologists don't give you that level of detail, because that's not what we're interested in either. And because there's so many different technique systems out there that look at that, we leave that to the individual practitioner. But that being said, we shouldn't use radiography as a screening tool, because if you use that instead of a good history and a good exam, then you're missing a lot of stuff.
one of our good friends, Michael Shacklock, he always says that, imaging isn't the problem. It's the education off the imaging that's the problem. And so that kind of speaks to what you're saying right there that's absolutely right. Do you have some?
Well, I was just going to ask Dan, in a stratification of medicine, so with chiropractors typically being low man on a totem pole, where are the DACBRs matching up with the medical radiologist? Are you guys, on level playing field now, or is it still slided, or where are we at?
Yeah, we're definitely not on a level playing field. And, you guys probably know this just from living the life of a chiropractor, that there's obviously some different levels of knowledge and acceptance out there. Our group of chiropractic radiologists is relatively small, especially when you compare it to medical radiologists, right? I think there may be, I don't know, maybe 150 to 200 active practicing chiropractic radiologists at any given time. So that's not very many people to make a big footprint or a big impact in the larger healthcare world. So a lot of the inroads that chiropractic radiologists have made over the years have been more on an individual basis. Just like with many chiropractors, they've been able to make inroads in their local communities just by building relationships of trust, showing other providers in the area of many different disciplines that that they're competent, they know their stuff, and that's where a lot of chiropractic radiologists have been able to do a lot of good work, and that's kind of where my ultrasound journey has taken me, and that's a lot of what it taught me, is that we're not on a level playing field. In fact, most medical radiologists aren't even aware that chiropractic radiology is even a thing most of the time. And so that's often a shock when I'm at a conference and I bring up that I'm a chiropractor and a radiologist, a chiropractic radiologist, if you will. And that usually surprises them and prompts a lot of questions about what we do as chiropractic radiologists. So, and another thing that is an issue for us in chiropractic radiology is, of course, reimbursement models. Generally speaking, we interpret our primary income source as a radiology practitioner is based on consultation with other chiropractors. So we haven't broken into other avenues, imaging centers, hospitals, quite yet. And some of that has to do with reimbursement systems in medicine in general. For example, most chiropractors are well aware of our situation with Medicare and how that impacts reimbursement for imaging generally. And that's a big block when it comes to us expanding into areas where potentially we could be helpful in providing image interpretation services, but those imaging centers would have a tough time getting reimbursed if, for example, me as a chiropractic radiologist, we're doing the primary reads of Medicare patients, which is a big chunk of the imaging volume that's done, at least in the United States. So there's still some issues that need to get worked out if we're looking to expand our reach and to get full inclusion. But otherwise, I always tell this to residents and students, there's never been a better time to be a chiropractor, and there's never been a better time to be a chiropractic radiologist along the same lines. The opportunities that exist today are things I couldn't even have imagined when I finished my residency, roughly 12 or 13 years ago. So things are trending in the right direction, but they're nowhere near where most of us would like it to be as far as opportunities. And so that's why most chiropractic radiologists often don't just do imaging full time. They often do chiropractic practice part of the time and imaging part of the time, or they do some teaching at a chiropractic institution part time, do their radiology practice part time, or any combination thereof. So for example, I see patients at Mercy Hospital clinic part-time, so I still see patients, which I really enjoy, and but I really like radiology too. So there's that.
What grade would you give the profession, it being able to order the right imaging or advanced imaging at the right time, and et cetera? Do you think the profession as a whole is doing a good job of that? Do you notice like the contemporary chiropractor being better than maybe some of the older chiropractors, or how good are we at knowing when to order the right imaging, and then what imaging to order?
Be brutally honest too.
You want brutal honesty here?
Yes.
All right. I don't want to give you guys too much hate mail, but
well, this could lead you to teaching a class under Gestalt education.
Excellent. I would say that there has been improvement from what I guess you could call the older generation to the newer. The understanding of when to choose which imaging tool has improved, but that's still a lot of what I do as a chiropractic radiologist, is I consult with providers in the field, and a lot of the time the questions I get still show that there is an educational need out there as far as what are the indications and contraindications for specific imaging tools. And like most things in life, it really does come down to exposure to those things. A lot of times chiropractors aren't that familiar with all of the options as far as advanced imaging goes. And a lot of the time chiropractors don't understand the limitations of plain x-ray, for example. They think x-rays can show a lot more stuff than they really can, which is not the case. So there's always room for improvement when it comes to that. And I think if you use imaging as a tool, as any diagnostic test, that's where it becomes the most beneficial to the patient, which again is our whole focus, is to improve outcomes in our patients. When we use radiology for any other reason, then that's when perhaps the outcomes aren't as affected. For example, if I need an x-ray to tell me where to adjust a patient, and this is going to be a controversial statement, I know, but if I need an x-ray to tell me where to adjust a patient, there's no evidence to show that that improves outcomes in patients, right? So how do I know where to adjust patients? Of course, there are many ways to tell you that. And again, most of them involve using our hands and our eyes to figure out. So that's kind of the educational bridge that I think over time has shifted, has improved. I think through the efforts of more evidence informed and less, proprietary technique driven treatment algorithms and treatment protocols, we've been able to get away from having to draw a bunch of lines on an x-ray to decide where to adjust a patient, versus using the imaging how it's best used, which is looking for serious spinal pathology, which may affect outcomes. But when our clinical exam doesn't suggest it, we use our hands, we use our other tools, whether it be a functional screen, whether it be a McKinsey type protocol. Those show greater benefit in helping us improve outcomes than taking a picture with X-ray photons, as it were. So there is always room for improvement, because it's sometimes a struggle to help chiropractors decide which advanced imaging tool is going to be best, but also knowing the limitations of these tests is so critical. And I think there's just an overestimation of what radiography can give you from a clinical information standpoint. So I generally harp on these three questions anytime anybody's thinking about radiography or any other diagnostic test. The first question they need to ask themselves is, will this image give me any information that I couldn't have gleaned from physical exam or history alone? And if the answer to that question is no, probably not, then you don't need to do the test. It's that simple. But if you say, well, maybe, then we'll say, okay, let's get the test. Okay, so that information that you get, is that going to impact your treatment at all? So let's say you have a 50, 60-year-old individual, and you want to know if they have some degeneration of their spine. Well, odds are they're going to have it, especially if you take an x-ray, you're going to see something. But is that going to change your treatment, your management? Probably not, unless there are other clinical signs. But the picture itself, the images itself, are not likely to change your treatment approach. So if you can't answer that second question, then you probably don't need to take the pictures. And the biggest question, and most important, of course, is the third one in that little progression. Well, will that change in treatment or that additional information, will that improve my patient's outcomes? If the answer to that is, I don't know, or the answer to that is no, then that tells you that you don't need to take the picture. You just need to initiate a trial of care and go from there.
Awesome.
Yeah, it's perfect. So let's switch gears maybe a little bit from advanced imaging. And you said that musculoskeletal ultrasound has kind of gotten you in the door in a lot of these conferences and leveled the playing field a little bit with the radiologists and stuff. And what first piqued your interest with musculoskeletal ultrasound, and you know, where are you at today from where you started?
Yeah. So I got interested when I was a resident in musculoskeletal ultrasound. There was another resident whose name was Bill Ersprung, who was training for a triathlon, and as a result developed some knee pain. And he saw a local provider here in the Chesterfield area that did some diagnostic ultrasound. And before that, I had really heard of it or thought about it applied to the musculoskeletal system, but he had an ultrasound of his knee. He brought the pictures back, and I thought that was so cool, the coolest thing ever. So from that point on, that was about 2006 when I first got my interest peaked, and then it just grew and exploded from there. So Logan, we got our first ultrasound machine in 2007 and started scanning at that point. And one of the things I love about ultrasound, well, there are two major things I love about it. Number one, I can kind of springboard my cross-sectional anatomy knowledge that I had to really work on to develop for MRI and CT. A lot of that comes in pretty handy when ultrasound is a cross-sectional anatomy tool. So being able to take some of that knowledge I already had and kind of translate it to ultrasound was fun. It was another imaging tool. But the other cool part is I got to actually use my hands to generate the image. So I got to interact with patients again. I wasn't, as radiologists, sometimes we get stuck in these dark rooms looking at images on a view box or images on a screen. But ultrasound got me back interacting with patients, which is something I've always enjoyed. And so that was a nice little melding of the two worlds, of the patient care side and the ultrasound side.
I think pretty cool. Dan, don't you think, with it being a dynamic test, I mean, that's the other really nice benefit for different areas of the body.
Oh, for sure, for sure. And that's one big advantage that ultrasound will always have currently over any other imaging tool, except maybe fluoroscopy, but definitely over MRI when it comes to imaging muscles, tendons, ligaments, nerves, joints, is that we can dynamically assess in real time a patient. So if we're looking at the ulnar collateral ligament of the elbow, for example, we can dynamically valgus load that elbow to check the integrity of that ligament in real time, which is a great advantage in certain circumstances. For example, we have an inguinal hernia on the schedule for this afternoon that we were able to image that patient standing or under a Valsalva load to see if they have a hernia that wouldn't be that obvious unless they did a Valsalva MRI, which aren't done very often.
Or like for a sports hernia,
hernia.
That's a very good add-on.
Correct.
So, we utilize it a lot for the ankle, for the medial elbow. I don't know, if that's what you found chiropractors utilizing it most for also, but I'm curious to know, like, is it going to help us with labral pathology in the hip and the shoulder down the road? I know now you guys are able to see it, but it's still not quite as good as the arthrogram. So do you see it going that way, or what's your thoughts on that?
Yeah. So I'd say the most common exam we do is still a shoulder rotator cuff exam. So ultrasound has shown, there are many, many studies now that show that ultrasound's accuracy for cuff pathology is similar to MR, standard MR. And so it's really is still the go-to test for rotator cuff pathology. Now, when we get into
insurance reimbursing it yet or not?
Sure, insurance is reimbursing currently.
Wow.
Depending on your contracts with insurance companies, chiropractors have been getting reimbursed by insurance companies for doing diagnostic ultrasound. But that is an issue that's going to be interesting to see how it goes in the future, I must say. And it's not just because chiropractors are doing it. Let me kind of set the stage here a little bit. There was a period of time, I think it was around 2009, 2010, somewhere around there, where a couple of Blue Cross Blue Shield insurers decided to stop reimbursing musculoskeletal ultrasound. Because in the past, there was only one code, a 76880 code. And so they saw this huge spike in utilization of that code. And so they decided to just stop reimbursement until they could figure out what was going on. And so that impacted a lot of providers. And so made a lot of noise. And so now and the reason there was this huge spike is because of utilization of this tool by clinical practitioners, right? Ultrasound, even though we have it in our radiology department here at Logan, ultrasound is a tool of the clinician in its purest form, right? Even if you look at echocardiography, ultrasound of the heart, people don't go to the radiologist to get that done. They go to the cardiologist, the clinical provider, to get that done. And so what happened in the musculoskeletal world is a few different provider types, especially podiatrists, started using ultrasound a lot for imaging Achilles tendon, plantar fascia, things like that. And so that's what caused this huge spike in utilization rates that ultimately led to a temporary, stoppage of reimbursement. But once that all got sorted out, reimbursement's been okay for the most part. And as far as I know, depending on where you're at, of course, in the local insurance environment, it's still being reimbursed when it's appropriately applied and when the typical ultrasound protocols are followed. So just to answer your second question about labral pathology, currently, ultrasound is not accurate for labral pathology of the shoulder. There are some studies on anterior labrum in the hip, but just that little narrow slip of the labrum there, where there may be some decent specificity, but sensitivity is still pretty limited. But as the technology advances, as probes in particular become better, the problem with the labrum in the shoulder is that there are just things that block us from getting a good look at it, bony structures primarily. So as the technology advances in the ultrasound machines themselves, there may be a time where we can adequately image the labrum because we'll get better resolution from deeper structures. We'll be able to maybe steer the ultrasound beam a little bit better around bony landmarks so we can have a good acoustic window into certain locations. And so, but currently those are the biggest limitations of ultrasound is if we don't have what we call an acoustic window into the structure, we can't really image it accurately. And that's our trouble with the labrum in the shoulder, especially superior labrum. It's superficial enough that we should be able to get to it, but it's just blocked by the acromion to a large degree. The coracoid gets in the way. Because that's the other big limitation is the depth. The deeper the structure, the less resolution we can get on our ultrasound. So depending on the patient's size, that may put the acetabular labrum out of reach and often does, especially in larger patients. But
the orthopedic surgeons, will they ever do a surgery only off ultrasound? Are they still kind of always, ordering the MRI at the end of the day before the surgery? Have you noticed a transition there? Is it always?
Yeah. So largely, most orthopedic surgeons that I have interacted with, ultrasound was a fairly new imaging tool for them. And so most of them were not confident in doing surgery off of ultrasound imaging alone. Therefore, MR was often done in order to plan the surgery. But there are orthopedic surgeons who are comfortable enough with it that they will do rotator cuff repairs, for example, in the shoulder is generally one of the more common things done, just based on the ultrasound imaging, because you can accurately measure the size, the dimension, the location of the tear, the defect that they want to repair, and they won't need to go the MR route. But that all has to do with how comfortable the surgeon is with ultrasound imaging. And And more, this is becoming the feature of their surgical residencies, is how to use ultrasound. Unfortunately, not so much on the diagnostic side, but on the needle guidance side, when they're doing needle guided procedures, that's really where ultrasound has gotten a lot of utilization on the medical side, is guiding needle-based therapies, whether it's corticosteroid injections, whether it's PRP injections, prolotherapy, whatever. If there's something that's delivered by a needle, ultrasound can be used to guide it exactly where you want it. And depending on where you practice as a chiropractor, sometimes ultrasound can be a guide for things like dry needling of trigger points and things like that.
Awesome.
Yeah, that's really good. What so you kind of discussed it, the elbow, the ankle.
Yeah.
What about like wrist and hand, anything like that? Where else do you like see ultrasound maybe becoming the gold standard, or is the gold standard? Give us 5 years down the road, maybe.
Okay, I'll give you today and 5 years down the road. So today, ultrasound should be the first line imaging tool for rotator cuff, for most muscle injury, as long as it's superficial enough and easy to get to. For elbow, wrist, hand in particular, knee, most of the superficial knee, like collateral ligament injury, quad patellar tendinopathies and tears, Baker's cyst, all that can be evaluated accurately with ultrasound. It's the internal structures like ACL in particular and cartilage that ultrasound can't see. So maybe in the future we'll get better at imaging the ACL and the PCL and the femoral cartilage. But with the knee, we can image the extensor mechanism really well, the collateral ligaments, and many of the superficial bursae, ankle tendons, Achilles tendon, plantar fascia. Those are some very commonly ordered scans of the lower extremity. Ultrasound has shown a lot of usefulness in peripheral nerve entrapments as well. Specifically, most of the data exists in the carpal tunnel and the cubital tunnel, but there's data for other locations as well that ultrasound is comparable to nerve conduction studies for diagnosing carpal tunnel syndrome just by measuring the cross-sectional area of the nerve, because when nerves become entrapped, they develop intraneural edema and they get bigger. And if they exceed a certain size based on ultrasound, that fulfills the criteria for diagnosing carpal tunnel syndrome, for example, which has comparable sensitivity and specificity rates to nerve conduction velocity. So ultrasound for peripheral nerves is also an area that highlights its ability, because the resolution of ultrasound is actually better than MRI, the spatial resolution. In other words, I can resolve the individual fascicles that form the median nerve, whereas that's a little tough to do on a standard MR coil. So
we'll have to have you out, Dan, when Shacklock comes this summer.
Yeah, man.
That would be awesome to bring a unit out. And I mean, he would love to be with you. So that would be great.
Yeah, that's an area that's still, I think 5 years down the line, a few people have been working on this, and that's, we did a very small study here where we measured static nerve translation. There are a couple of people that have worked on measuring how far the median nerve slides and glides during some neurodynamic testing under ultrasound, and have found differences in symptomatic versus asymptomatic. So maybe in 5 years, we'll add a little more of the dynamic component with a little more, objectivity. Right now, it's not quite there, but that's always fun to image how nerves move and do it in real time.
You got to. What's the weekend of that?
It is in September. Yeah, so we'll. Oh my gosh, that's a given. So we'll have to do a little a mini video tour of maybe you two doing Shacklock doing some neurodynamic tests with you, doing some measurements along the way and stuff. That'd be so
I think it's
cool.
August, but I could be wrong.
August, end of August. That's right,
Yeah.
end of August. So, well, that's awesome. That gets me excited. So, Shacklock and Dan Haun. What could be better?
Sounds fun. What could
be
better?
Maybe the last question, Dan. I know that a lot of our viewers are in clinical practice.
Yep.
Now there's portable ultrasound units that you can get for basically $2,000 that a lot of people are kind of investing in. And I know that you've kind of headed the education for expanding the knowledge of ultrasound. Where are those units at as far as integrated into practice, and is there usefulness? Is there, your opinion?
Great question, boy. So I'll try to be brief on this. So as technology improves, the application of ultrasound in the clinic is only going to become more common. So again, ultrasound is moving outside of the radiology department and into the clinic. So individual clinical providers are going to be the ones probably in the future doing the majority of the ultrasound scans. And the smaller the units become, the more likely that is to happen, and cheaper, right? Let's be honest. So there have been a couple new innovations on the ultrasound technology side of the deal where they now make these probes which have all of the hardware basically inside the probe itself. So all you have to do is plug the probe into an iPad or into a phone, and you have a very inexpensive entry-level device to get you started into the ultrasound world. And I'll admit the images of those aren't exquisite, but they're also not terrible either. So I remember when I started in ultrasound, I used some bigger machines that didn't take better images than what we can now hold in our hand and on our phone. So the technology is improving, it's getting there. And so that's what I would advocate, that those units are a good way for people to see if it's a tool that they're really interested in. And you can start getting your scanning skills up to snuff, because that really is one of the bigger issues with teaching yourself to do ultrasound, is just getting your hands on a probe and on a patient and just practicing the different imaging protocols for whatever you want to look at, right? So there are some standard images that we assume will be done with any particular region, but the low cost of those, the wide availability of them, are only going to drive more and more people to do ultrasound in the clinical setting. So here's where it can get a little tricky, and I don't know where this is going to end up. So this is just something to think about, because it is going to become more and more common, right? This is called point of care ultrasound. Some people call it POCUS, P-O-C-U-S, point of care ultrasound, where the imaging is done at the point of care. This has gained a lot of traction in the medical side, especially with emergency medical physicians and rheumatology and others. But the issue is that, how do we bill for that service? And I don't have a snappy answer for it, right? Is this just part of the physical exam? We just use ultrasound as the so-called stethoscope to the joint, because we don't bill for a separate code when we auscultate somebody's heart, for example. Or do we bill this as a separate imaging service? And I would say most people who do ultrasound in the clinic aren't billing it as a separate service. So then it's kind of getting lumped into the physical exam, however you bill that out, whether it's insurance or patient pay, whatever the case may be. I know in the ultrasound world, that's a big question that always comes up at every meeting is, what is going to happen to ultrasound reimbursement down the line? And I have no way to predict, but
how they should do it, it should be off what your training is. It'd be no different than like me looking at an x-ray versus you. I mean, right. I'm a novice at looking at x-rays. So, I mean, I can, to add another one of the problems I foresee in the future is you got a bunch of people that don't know what they're doing looking at this and then, interpreting. So add that to the list of maybe the problems, but
for sure.
So yeah, maybe the reimbursement should be on like what your training is, but.
Yeah, and some steps have been made. So there's this big group called the American Institute of Ultrasound and Medicine, the AIUM, that actually has a document that says who can and perform and interpret musculoskeletal diagnostic ultrasound examinations. For a long time, chiropractors weren't on that list. And for a long time, ultrasound was like the Wild West. If you could buy a machine, then you could do it. And the AAUM has tried to standardize the application of ultrasound across the board. They're a multi-specialty organization, so they're not just musculoskeletal ultrasound. They're OBGYN. They are head and neck vascular stuff as well. But anyway, they invited chiropractic to the table to get into the latest revision of the document, and they did include us in the document, but it came with a couple stipulations, and that just has to do with the different ways chiropractors are trained. For example, when we went to that meeting, a couple of the specialty groups were very concerned that chiropractors aren't residency trained, right? Because that carries a certain meaning in the medical field, right? If you haven't done a residency on the medical side, that kind of stigmatizes you quite a bit, right? Because that usually says something about your qualifications. But on the chiropractic side, that's the norm, is to not do a residency. And so when we were trying to get chiropractic included in that document of who can and cannot do musculoskeletal ultrasound, a lot of people were hemming and hawing that chiropractors weren't residency trained. So as a result, we came to a compromise that said that if you have diplomate status with the American Chiropractic Board of Radiology or the American Chiropractic Board of Sports Physicians, DACBSP, those are the two specific specialties within chiropractic that are now in that document. But does that mean that the general practice chiro cannot do ultrasound? No, because we were doing ultrasound before that, and that document can be changed at the next iteration. So far, to my knowledge, no third-party payers have used that as a reason not to reimburse anybody, because I know there are plenty of chiropractors that don't fit those specific two specialties that do great work in ultrasound. And so
when you guys teach your course, Dan, are they supposed to make an impression like on a legal document, like you would like an x-ray report, or it's not to that level, or not?
No, if you bill the ultrasound code, 76881 is the full ultrasound exam code. The assumption is you also generate a written report for that. Yeah.
Gotcha. Yep.
Yeah. So, but that's not, well, with training that can be done pretty easily, pretty straightforward, depending on the area you're looking at. But yeah, that's assumed to be part of the procedure if you're billing the full code. If you're using it as an extension of your physical exam, then there's not really a need for a written report to be generated.
Other than performing a diagnosis on your
that just goes in your clinical note saying, my physical exam says they have Achilles tendinopathy. Let me slap the probe on there. Oh, sure enough, they've got Achilles tendinosis with hyperemia and thickening of the tendon. So that just goes to confirm your clinical suspicion. You could bill that. There is a limited ultrasound billing code, but then it would require still a written report to accompany that code. Otherwise, you just include it in your clinical note as adequate documentation. But those are kind of the unanswered questions in the world of musculoskeletal ultrasound, especially when it comes to how chiropractors utilize it, because most chiropractors that use it aren't DACBRs, and they aren't necessarily sports physician or DACBSP certified. Bill Moreau, who was with the USOC at the time, was instrumental in getting us as a profession to the table, because through the USOC, he made some inroads with the musculoskeletal ultrasound world there and utilizing it on the Olympic athletes. And that allowed us a seat at the table. And so we're able to make some inroads, and hopefully we'll continue to do so. But that's the current status as it goes. And we're always looking to offer clinical or ultrasound training programs. We had one through Logan's postgrad that ended maybe a year or so ago. And we're looking to offer other training opportunities here shortly. My colleagues, Pat Battaglia and Ross Maddox.
Bunch of losers they are.
I know, right? I should never hang around with those guys.
No, they're bringing you down, bro.
Oh man.
No, well, yeah, we'll talk about Gestalt and what that could mean for everybody. Yeah.
Yes.
The good news is that musculoskeletal ultrasound, I mean, talk about a much more inexpensive, and as long as it keeps progressing how it is, holy, I can't wait to see what it looks like in 5 years. And
Oh yeah.
the fact
For a
that
chiropractor, I mean, if you're deciding, should I get an x-ray machine for my office or should I get an ultrasound? I think that question is more and more pointing toward, especially as cost comes down for ultrasound units, that's the imaging tool that's going to give you more bang for your buck, most likely.
I can see for me working, I work at the high school, and then I work sidelines a lot too. I mean, to be able to have that unit close by to make kind of decisions on next steps. And I mean, that,
Oh yeah,
that could be huge down the road. Huge. So
indeed.
Anyway, well, what an interesting conversation. I learned a ton about not only diagnostic ultrasound, but the life of a DACBR. And Brett, any closing thoughts? Or
I just had one more question before we move on here.
Yep.
When you guys get together, what do you make fun of the rest of the profession about? So what are some of the things that you guys kind of behind the scenes make fun of the traditional, I guess, chiropractor?
As DACBRs?
Yeah.
Oh man. It's DACBRs. It's mostly, it's kind of a self-perpetuating joke because many of our group is involved in training of students. And so it's a lot of the same old stuff that, you know, some of practitioners will wonder if they even know the difference between a spinous process and a transverse process on an x-ray. Now, of course they do. That's a joke, but sometimes we wonder, you know, we tell stories like, this is a story I like to tell because it really happened. I was sitting in our reading room one day, and a local provider comes in and says, I need you to help me look at this image really quick. I mean, he drove there from his office. He was so worried about this image. And so this was before we had digital, so that kind of dates me a little bit. But he put it up on the view box. He's like, I think my patient has cancer. And he pointed to, it was an AP lumbar. And he pointed to this big black thing. He's like, that big black thing up there under the diaphragm, I think that's cancer. And of course it's not, it's just the gastric air bubble. But stuff like that happens more often than
I would not want to know.
No.
So then we're like, oh, no, your patient's fine, actually. No, that's just the gastric fundus. And again, it's not that chiropractors are less intelligent or less able. It's just the time it takes to do something well, they just don't have time to do it amongst the million other things you have to do to survive in private practice. And so that's why our specialty exists, to help in that regard.
That's why I had a great education at Cleveland. We had great radiology department, everything. However, I still feel incapable when I look at an x-ray and stuff like that. And so that's why we send all of our imaging out to people like you that this is what they do. This is their expertise. Why not lend expertise to other people? That's what collaboration is all about. And that's what integration is all about, right?
Correct. And that helps our patients.
Yeah, absolutely. Well, Dan, thank you so much for sitting down with us. Congratulations again on your award from the ACA. You're well deserving. I know I've learned a ton from you over the years, even just kind of walking through the halls of Logan and hanging out with you a little bit at MPI Club and stuff. So I'm truly grateful for getting to know you. And with that being said, keep crushing patients, guys, and stay tuned for next time.